Oliver. The particular thing about Oliver is he's travelled a long distance to be here, and certainly of all the medical people I've talked to, Oliver seems to have the broadest knowledge of all ports. So I'm very keen for you to hear from him.
Well, thank you very much. It might be everybody's able to hear me, but you might not be able to understand me because of my German accent. So my first slide is actually the most important publication of this year, because we have the first international expert recommendation how we actually should treat Alport syndrome. And the most important point is that we need to make the diagnosis first. You will see that we will tell the doctors if we do a kidney biopsy, it must be including the electron microscopy to see the very tiny bits of the kidney. And we know that if you do genetic testing, we need a genetic counseling with that, because we know that in some areas, genetic counseling is not a must if you do genetic testing. You will see that we actually do not really distinguish between female carriers of X-linked Alport syndrome or thin basement membrane disease, these autosomal recessive carriers, because if they have additional risk factors like hypertension, or if they take a lot of pain medication, they should be treated with ACE inhibitors, or if they develop proteinuria, they should be treated. They should be checked on an annual basis, and they should be aware that they have some risk of developing renal failure. It's hard to tell how high that risk is. It might be between 10 and 20%, but it's hard to tell because our registry is still too small to decide on that. And we have the first recommendation to treat children with Alport syndrome once they develop proteinuria. And remember, that was a publication in the beginning of this year. That means it's not in the textbooks right now. So you need to tell your doctors about the therapy of your child. And we have an agreement that if the children would be treated earlier, we should do that in a prospective trial. We shouldn't do that just by, it might help or it might not help. And finally, we all agree internationally that all patients on treatment and without treatment should be registered, should be reported in registries, because we want to know about side effects and treatment effects. So this was published in the biggest pediatric nephrology journal, and it will be something like that, will be published pretty soon in the biggest adult nephrology journal as well. Well, I was asked to explain why female carriers should be treated. If you look at a normal kidney, this is just tissue staining of a normal kidney in different colors. Green color is scar tissue, and the yellowish color is just normal tissue. And if you compare this to mice with carrier state of Alport syndrome, you see that you have tiny little bits of scar tissue and a little bit more of normal tissue in the kidneys. That means you need to remember that some of our expert recommendations are from experiments in mice, and you need to decide on your own if you are that similar to mice that you can trust our expert recommendations or not. A reason why you might trust us is that we collected data in what we called European Alport Registry just by picking up the mothers of the children with Alport syndrome. And we found out that the mothers with proteinuria that are treated with ACE inhibitors are much less likely to develop renal failure throughout life. It doesn't mean that, of course, not everybody being a carrier develops end-stage renal failure. We just picked the bad, outcome mothers here. So don't think that everybody will develop end-stage renal failure. You understand what I want to say? Yeah. Okay. So I didn't expect that huge effect of ACE inhibition because mothers that are affected, severely affected, are more likely to be on medication. So even the more affected mothers being on medications are doing better than the less affected mothers not being on medication. So that's a strong recommendation for treatment of carriers. Well, Neil was telling you about the washing machine, the kidney. This is just one glomerulus, one filtration unit, and you need to remember you have 1 million of these filtration units here. So this is an outside look on this glomerulus, and you see that one little red blood cell here. You will see that in a larger magnification right now. So this is just looking inside the kidney. This is one red blood cell here. And all the black spots here are the naked basement membrane. That's normal in humans, in every mammal. If you take away all the cells here in a normal individual, you see that the glomerular basement membrane is just smooth and well looking. And in an Alport patient, it's looking like, a Swiss cheese, we would say. So you get an impression what the problem of Alport patients might be. And it's a lot easier to explain it to children because if you look at this filtration unit as a washing machine, and that's actually what we do if we explain the disease to children for our trial, is that this washing machine normally gets rid of dirty water, but in Alport syndrome, you lose dirty socks as well. So what can you do about it? Well, even the washing powder is important. Like if you take too much salt or if you take too much pain medication, that spoils your washing machine, and that's true. And we need to take a medication to reduce the spinning speed of this wheel, like ACE inhibitors do. And this medication also might affect the effect of the smelling socks in the rest of the kidney. And actually, the children intend to explain it to their parents that way, and I think the parents are lucky that they understand what. Once again, why do we recommend medication in children with Alport syndrome? The only really good scientific evidence we have are for mice. Mice with Alport syndrome, every mammal has Alport syndrome. Like there are dogs, cats with Alport syndrome, but mice also have Alport syndrome. Mice die from end-stage renal failure with 10 weeks of age. But the sooner and the longer you give ACE inhibition, the longer the mice live. And the longer means they live more than 100%, double the time until they develop end-stage renal failure. What is actually the problem with these kidneys? If you remember the dirty socks, these are the filtration units. There. But the main problem for the kidney is the sink of, well, the kidney after that filtration units. So all these dirty socks were actually stuck in the kidney, and well, that's what we call scar tissue formation. And in treated mice, you see that you still got some problems in the filtration units, but the dirty socks don't cause that amount of damage anymore. And it might be that easy to explain the effect of ACE inhibition. I did that experiments more than 10 years ago, and what we actually started by the help of the French patient group is to collect data throughout Europe. And if you look at this data, this is, well, your time of birth and your age, up to 50 years of age, and the percentage of patients on dialysis. Because it's quite easy to ask patients, well, what was your age when you started dialysis? Everybody remembers that date. The red line here are the uncles of children that were treated, and the uncles were not treated. So we know that in Europe, the average age of end-stage renal failure in untreated patients is 22 years of age. However, if you treat patients with ongoing renal failure, we were able to delay end-stage renal failure by 3 years. That's still significant. So that means that we see an effect here. If we start ACE inhibitors in patients with proteinuria, it delays it by a mean age of 18 years. But you need to remember that this is statistics. So you can't really trust that every child will be delayed by 18 years. It might be one with, well, a delay of 5 years, one with 8, one with 20 years. All we can say here is that it looks like the sooner we start, the better the patients do. And the major question right now is how early can we start, and how early we can start treatment without harming the patients because we treat too early. This is actually a major question for pediatric nephrologists because it's a huge safety issue if you treat a 2, 3, 4-year-old child for 20, 30 years with a medication. So remember this question marks here because that is the main reason why we recommend a clinical trial here. We were able to confirm these registry data throughout Europe by looking at a dialysis registry in Europe, telling you briefly that between 1990 and 2004, the average age of end-stage renal failure was 26. And after that, it increased by more than 6 years. So it looks like since a few years, there is a treatment effect of any medication in Europe that affects end-stage renal disease in Europe and, of course, in the States as well. So there is an ongoing, well, treatment that affects renal failure. We think it is ACE inhibition. So let's go back to the question marks. We were lucky enough that the German government decided that they were able to finance a clinical trial in German Alport patients. And we are actually targeting the safety issue of how early should we treat children with renal failure. You might recognize that, Ramipril is the ACE inhibitor we recommend. Some of the patients are not treated. They are treated with placebo. And that means that we are not sure if this medication is better compared to placebo in that early stages of disease. Otherwise, we would never be allowed to take a placebo that, well, of course, doesn't alter the course of Alport syndrome. The costs of this trial is €1 million, mainly because the safety issue and the controls of the patients are that strict. It's nothing else you would do in an outpatient clinic in Edinburgh. The costs actually are to follow up the patients. One great thing about the trial is the patients we cannot offer to be in that trial because, well, they are already have proteinuria. We tell them there is an international consortium where we can collect the data for the next generation of clinical trials. We think it will be the only in advance clinical trial in Alport syndrome ever done in this type of setting. So we would be more than lucky if any other countries could join us. It doesn't really mean that the patients need to travel to Germany. It would be much better if London, for example, would be able, or Edinburgh would be able to, put a similar setting and we could just combine our data. The endpoints of the trial, as I said, is mainly a safety issue. So we recognize the concern of pediatric nephrologists that we all do not know how early we can start. We know the earlier we start in mice, the better it works in mice. But again, you need to decide in your children if this is good enough to treat your children or not. So my conclusions is the most important point actually is Alport syndrome has become a treatable disease. And looking back 10 years from now, even looking back 1 year from now, it was not a treatable disease regarding the official recommendations. So we have the official recommendation, it is treatable. That means genetic testing will become much more important. We recommend ramipril. Actually, ramipril is just one ACE inhibitor, but the safety data from ramipril are the best we can have because we had a German trial regarding hypertensive children. So we know that ramipril is quite safe in children. Therapy should be started in carriers and patients if they have proteinuria. Patients should go to see their doctor. Children with earlier stages of disease should be treated in trials, not just on an individual basis. We do not know yet if that drug might even affect hearing loss, but we will look for it in the trial. It might be that it affects hearing loss. And, sorry, I called it familial benign hematuria. It should be benign familial hematuria. And we don't think that benign hematuria is a good name for that kind of disease, because once you develop microalbuminuria, it's not benign. You should be treated. And you should be aware that you're at risk. So finally, I thank you, and I thank the French patient group that already left, because you need to be aware that without that French patient group, we would never had this European registry done. So my message might be, it doesn't really matter in which country you live. If you have Alport syndrome, you should combine your efforts to, find a cure. Thank you.